Good evening, everybody. Welcome to Neurology Lecture Series. Today, the topic is Approach to Cognitive Impairment and Bedside Testing of Cognitive Functions. We have Dr. Prabhagar here, who's a professor in Department of Neurological Sciences in CMC Bangalore. If you have any questions, please, we have time at the end of the session to ask, or you can enter it in the chat box. Over to you, sir.
So very good afternoon to all of you. So today we'll be looking at how to test cognitive function, and I'll also be giving you a clinical approach to cognitive impairment in the OPD setting as well as in the IP setting. So at some point in life, all of you would have wondered, where am I going? What am I doing? And what is the meaning of life? So if you're able to do that, that means you have a fully functional mind. And that mind is because there is a functioning brain underneath that is producing the mind. And so let's ask by starting, what is the function of having a mind? So any guesses? So simplistic way of looking at it is that the mind helps you survive in day-to-day life. So it gives you memory from which you can learn from the past. It helps you to deal with the problems of everyday life, and it helps you to predict the future and look towards tomorrow with hope. So that is the purpose of having a mind, and underlying that is the brain, which drives all of this function of the mind. So let's start with some interesting questions. So here is a creature that is displayed here. So I want you to guess whether it's a plant or an animal. So it does look like a plant. It looks like a flower, but actually it's an animal. And this is actually called as a Csquared. So even though it lives at the bottom of the ocean. So if you look at it, the morphology of it looks very much like a plant. In fact, it looks like a flower, and life cycle you'll understand why it's an animal. So if you're wondering why I'm showing this creature, I'll let you know. So this is a life cycle of the Csquared. It starts off as a larval stage. It looks very much like a tadpole. It's a free living life form. It swims around in the ocean. It actively looks for food. So because it actively looks for food, it needs to perceive things in and around it. So it has a brain to perceive. It's got eyes, and it moves around. It escapes from predators, and then finally it becomes the adult life form. And if you see the adult life form, as it settles down in life, like a lot of us human beings, starts slowly losing its brain. So it no longer has to fight for food. All food that drops down to the ocean floor from above is picked up by the adult Csquared. So it doesn't have to move. Hence, it doesn't have to perceive the world around it. And hence, the brain it had as a larval stage gets completely digested. So this is a classic example of one of the primary purposes having a nervous system or having a brain is for locomotion. So, and why do animals have to locomote? Unlike plants, is that animals do not have a source. Rather, they do not produce their own food. So they depend on other animals or plants. And in the region around them, the food is exhaustible. So once you finish the food in one point, you may have to move to another point to get more food. So the primary purpose of animals to locomote is to find food or to fend themselves from other creatures that may want to eat them. And what enables them to do so is what we call as a brain and a nervous system. So I'll introduce you to this slightly complicated principle that underlies most of cognitive function. So this has been made famous by Professor Carl Freston, who's been called the father of modern neuroscience. So let's start from the beginning. So imagine something has to exist in this world. So rather not exist at a point in time, but exist over time. So that means you have. So let me remind you of something called as the second law of thermodynamics. So the second law of thermodynamics states that with time, disorder in the world keeps increasing endlessly. So if something has to exist, so it has to constantly fight against this disorder that is pulling you apart from in all different kinds of directions. So don't get carried away by the complex maths that is given here. So let's look at this a simple thought experiment. So imagine that you put a drop of ink into a jar of water. So as you can see in the picture below, so normally when you put a drop of ink, the ink rapidly diffuses because there are dissipative forces pulling it in various directions. So diffusion of the ink droplets happen and it moves in all possible directions. And this is what happens to most biological entities, so including our bodies. So if you were left without any forces acting on it, then you will find that we get dissipated in our environment. So that is how we die. But the purpose of being alive is to constantly fight the environment that tries to kill us. And how do we do that? Is now let's imagine that this ink doesn't get dissipated, but it forms a particular blob, as we can see here, and willfully moves from one point to the other. So how do you think that would be possible? So I would guess that the ink droplet has to constantly figure out which direction the forces are acting on it. So it has to imagine that it has to be able to perceive the environment around it, and it has to perceive that the ink droplet is getting pulled in different directions. And also it needs a motor phenomenon. So it needs to produce forces that act against the phenomenon. So that needs to exist over time, has to have some measure of how to perceive the world, to figure out what are the forces that act on it. And also it needs to act against the forces that try to dissipate it. So that is the basic principle of how organisms exist. This is true for both plants and animals. Plants do it in a different way. Animals do it in a different way. And animals have a brain, but plants do not. So let's look at another interesting concept. So if there are more questions on this, we can always come back to them. But this is a basic concept of why we need to have a brain and why in order to survive. So here is another ancient theory by another German biologist called Jacob von Uexküll. So he said that the entire nervous system consists of only two things. It's called the perception and action cycle. So as I told you that you need to perceive the world around you so that you know what are the forces that are trying to dissipate you. And also you have needs to survive in the world. So you have energy needs, you have personal needs. So you're looking at forces, you need energy to sustain yourself. So because of these, you need to perceive what is around you. And how do you act? So you need to act in this world to prevent or get away from these forces, or to act on these forces so that you can get energy. So if that sounds all theoretical, so let's look at the life cycle of a tick. So just Jacob von Uexküll actually looked at tick, and he found that the life cycle of the tick consists of a larval stage. It walks around, but instead of looking at it in a complicated way, he just looked at it as from the tick's point of view. There are only three kinds of things it can perceive. So if the adult tick knows that if there is a grass, it would like to climb on top of it so that it can be exposed. And once it goes there, it keeps waiting. And the next thing it knows in the world is the smell of butyric acid. So whether you're a dog, whether you're a cow, or whether you're a professor of neurology, all smell of the same butyric acid. So to the tick, all mammals which smell the same and all form a very similar entity. So it can't differentiate between one mammal and the other. And so once it gets the smell of butyric acid, it just jumps onto them, and then it goes and finds a warm. So it moves towards the hairless part and then starts sucking blood. And so from a tick's point of view, you will see that it is able to perceive butyric acid. It's able to perceive warm bodies, and it's able to perceive an area which is. And what does it do? It either moves towards it and then starts sucking blood. So you can see that there is a perception component to the tick's life, and there is an action component to the tick's life. So that is how it acts. So if you see that the entire life, the internal life of an organism is called as a Umwelt, and it consists of two things. It's a perception part and an action part. And this is what Uexküll actually explained. And now if you kind of complicate it with billions of years of evolution, and you will end up with this complicated human brain, which even though looks so complicated here, from a conceptual point of view, can be completely easily divided into the front of the brain and the back of the brain. So what is denoted in blue is the back of the brain, and what divides it is the central sulcus. So as a rule of thumb, we say that everything behind the central sulcus is the perceptual part of the brain, and everything anterior to the central sulcus is the action part of the brain. And together these two, along with the sense organs and the effector organs, help the brain to have the perception action cycle. So now let's put all of this thing together. So if you have to exist as an organism, you constantly have to fight the forces that try to dissipate you. And in order to do that, and if you're an animal, you need to move from place to place. In order to do that, you need to have a perception component and an action component. So the sensory organs, along with the posterior part of the brain, helps in perception, and the anterior part of the brain, or the motor component, helps in action. And if you can see that with the environment, there are various. So you can see that the primary sensory areas are very close to the central sulcus. The associative areas are slightly away, and the associative heteromodal association cortex are even further. So, and all of these are connected to each other at multiple levels. This is how the brain functions. So there's a perceptual component and an action component. And if you see the brain, there are the various parts of the brain are connected. So you can, one of the mathematical ways of looking at networks is something called as a node and edge model. So I would not like to you to pay too much attention to this, because there's an easier way of looking at it from a clinical point of view. You can see this as neural networks as one-to-one connections, one-to-many connections, many-to-one, and many-to-many connections. So let's assume that because we're going to be talking about cognitive impairment and neurological impairment, let's assume that there is damage to this pink node over here. And you will find that everything downstream to this will be affected. So classical example is the corticospinal tract or optic nerve, where there's just a serial connection, where this one-to-one connection. So if you have damage to one point, everything below that will have damage. So if you damage one point in the internal capsule or the motor cortex, you will have weakness all around below that. Now, if you have one-to-many connections, it's a divergent kind of network. So classical example is the brainstem reticular activating system. So if you have a damage, wide areas of the brain can be affected. So all you need is a metabolic disturbance or a structural lesion in the brainstem. Because it's a one-to-many connection, entire global cerebral dysfunction can happen. So then you can have many-to-one connection, like a large area of the brain can converge to close to one area. So classical example, even though it is the corticospinal tract, where the internal capsule, many fibers come together. So a lesion at one point, like say in the blue node here, can cause weakness of both upper and lower limb fibers, because all of them come together at one point. And coming to many connections, so these are all multiple parallel connections. So you can see that even if you knock off many nodes here, there'll be still connection between 2 points. So you'll find that certain areas like the parietal lobe, the temporal lobe, and the frontal lobe, you can have large lesions, but they may not have any deficits because of the many-to-many parallel connections in the brain. So this is a simple way to understand how neural networks function. So with this knowledge, we are ready to actually tackle two main cognitive functions. So there are two brain functions. One is called as the state function, and the other is called as channel function. So state function is nothing but one-to-many divergent connections starting from the brainstem, and it projects to bilateral cortices. So you need an intact brainstem. You need normal metabolic processes like a normal oxygen saturation, normal sodium level, normal resting membrane potential, normal pH. All of this projects to bilateral cerebral cortices and makes the brain receptive for sensory phenomena. And this is called as a state function. On channel function, on the other hand, are one-to-one connections in the brain. So these are like language function, memory, where one part of the brain is connected to the other part of the brain, performing one particular function. For example, the Broca's area and the Wernicke's area are connected, and that is a channel function. So the most important concept in this lecture is that you need to know that state functions depend on, rather channel functions depend on state functions. So in order for channel functions to function, you should have a well intact state function. So if you are already drowsy or unconscious, you cannot really comment whether the patient has got aphasia or a dementia or underlying problem. So to make this conceptually easy, so I'd like to call this the umbrella model of cognition. So you can imagine that the brain is equivalent to the canopy of the umbrella, and the handle of the umbrella along with the opening mechanism is the brainstem. So in order to see if there is any hole in the canopy of the umbrella, you should be able to open it. So without opening, you may not be able to say whether there is many holes in the canopy or not. So as I told you, the state function is tested by is a function of the brainstem. There are mainly the monoaminergics, starting from norepinephrine. There is 5-hydroxytryptamine, there is histamine, and GABAergics and cholinergics, all projecting to the various parts of the cortex bilaterally and diffusely. And these are the ones that are which is called as a state function. And channel functions are language, memory, executive function, all of which depend on state function. So, so this is a basic theoretical concept. So based on this, we need to assess somebody's state function. The state function consists of arousal and awareness. If the patient is not sleeping, he's got open eyes, he's responding to the stimulus, and he's attentive to whatever you're saying, that means his state function is good. And only if state function is normal, then you can assess the other channel function, which is language, memory, perception, and other things like emotions. And so it's possible that you may have dysfunction in language and memory and perception when the state function is abnormal. So you should not make a false diagnosis of things like language dysfunction and memory. So classic example is a delirium. Later. So there are some common screening tools that we use. So you must be already aware of that. And this test, so what this doesn't test is the state function. So you should be, before commenting on any of these scores, MMSE or MOCA, you should make sure that the patient is arousable and is able to at least, you are able to communicate with the patient, you're able to, and they're able to sustain their attention. So if they're not able to do this, you will find that you will get grossly abnormal scores in this and you will not be able to interpret it accurately. So, so coming to cognitive function, before we go on to that, I'd like to comment on two things. We'll go back to the umbrella model. So state functions and channel functions are there. Our general approach to cognitive function is that first assess state function. So patient has to be awake and aware and arousable. And then you can really say that his state function is normal or not. So if you have a acute onset state function dysfunction, then it's called as a delirium, or there is a structural lesion in the brainstem. So you find that patient is drowsy or hyper arousable and he's very restless or sleepy, then you say that the state function is abnormal. The commonest cause for that is a metabolic encephalopathy. It may be an infection like sepsis, it may be a hyponatremia, or always look for a structural lesion. So when will you suspect a structural lesion affecting state function? Look for pupils, look for eye movements, look for hemiparesis. So in a patient who is not arousable, who's got focal neurological deficits localizing to the brainstem, mainly which is either abnormal eye signs or who's got a hemiparesis or ataxia, then you would think of a state function problem because of a brainstem lesion. So if you get a confused patient who is not arousable, who has no focal neurological deficits, you will think of a metabolic encephalopathy or a delirium in this setting. So approach to channel function is that in a patient who is awake and arousable, if you find that they have insidious onset gradual progression of focal neurological deficits localizing to the cortex, which is either language dysfunction, memory impairment, impairment in executive function, or behavioral disturbance, then you will think of a dementia syndrome. And we need to consider a dementia when there's insidious onset, gradually progressive symptoms of memory plus another domain over a period of 6 months. So to summarize, if you have an acute onset state function dysfunction, then you think of a delirium, insidious onset gradually progressive channel function dysfunction with normal state function, then you will think of a dementia syndrome. So having said this, we'll go on to how we assess bedside cognitive function. So first we check arousal and awareness. That means if the patient is awake and sitting up and cooperative, then the patient who is drowsy, you may want to see if they're arousable, see if they're able to communicate. So the first thing that we do once we know that the patient is arousable is to check their attention. So the bedside way of checking attention is to do the digit forward and a digit backward. And this is called as a digit span. So the digits are said at 1 per second. So we normally write it down. So we have a written format like this, and then we show. And the patient is, and it's supposed to be one number per second. And the person is supposed to repeat it back. So normal digit forward span ranges between 5 to 7. And it varies with age and educational status. And it also depends on the motivation of the patient to do it. And digit backward, on the other hand, is a little more difficult. So people who are more educated, people who are more comfortable with numbers, and especially in the field of maths and science, are more likely to have a higher digit backward span. And people who are not educated or illiterate, who may not be able to do this, just does not mean that they have any disease, but it may be a normal phenomenon. So it's better not to overcall digit backward, but it also looks at the ability of the person to manipulate mental information. So the other thing that we also check along with attention is orientation. So they're able to say where they're located in space and what the time is also important. So after attention, we also want to know whether the person is able to sustain their attention. This is an important test to do, because if they're not able to perform well on this, that means the long cognitive testing takes a long time, and it takes a lot of motivation and effort from the patient. So if they're not able to maintain their attention over even a period of 1 minute, then you will find that all the tests will come abnormal. So vigilance test is what we do is called as a random letter test. We read out all these alphabets that is shown here in sequence, and the person is supposed to tap on the bench or on their lap whenever you read out the alphabet A, and you will find that if it's the few errors of omission are okay. If more than 3 errors of omission or any error of commission, that means the person's vigilance is not good. And if vigilance is impaired, it also means that not only attention, but reliability of all the subsequent tests need to be questioned. So in order to communicate with the patient and do other tests, the next most important thing in channel function is language. So the simple thing is to ask the patient an open-ended question and ask why they're there in the hospital, so that you'll know whether you're able to communicate with the patient, whether you're able to do and spontaneous speech. So once you assess spontaneous speech, you find that there's something abnormal, then you want to do three things. Three things that we check is: one is comprehension, repetition, and fluency. So comprehension tests the functioning of the Wernicke's area, or the perceptive areas of the brain, which is located in the posterior part of the brain. And repetition and fluency assesses the Broca's area. Repetition checks the connectivity of the white matter tracts between the Broca's and the Wernicke's area, which is also called as the arcuate fasciculus. So comprehension we do by two methods. One is by pointing commands. So you usually ask the person to point to common objects. You should avoid pointing to like body parts, midline structures, and to overcome neglect and field defects, you always ask them to point to objects on either side of the field, so that you're able to see whether they're able to point to commands. And if they have weakness, you can always ask them to look towards an object also, so that the main idea is to see whether they're able to comprehend whatever you're trying to communicate with them. Also, you can ask yes/no questions. These questions have to be objective questions and the patient should be having. That information should be available. So in a patient who's admitted in the ICU, is it raining today may not be relevant, but you can ask questions like, is the light on? Are you in hospital? So, or is your name so and so? So these are questions that will tell you whether the patient is able to comprehend or not. Repetition tells you whether the arcuate fasciculus is intact or not. So if the repetition is intact, then we're dealing with a person with transcortical aphasia. If repetition is impaired, that means we're dealing with a perisylvian aphasia. That means the primary language areas are involved. So we start with a single word and longer words and a sequence of words. So the number of words a person can repeat is usually about one more than the digit span of the person. So that is the normative value for that. So naming actually depends on the anterior temporal lobe, its connection to the language areas, and its distribution to wide parts of the brain. So it's got limited localization value, but you can get selective naming problems. So we ask people to name objects, body parts, parts of objects, and colors. Coming to fluency. So fluency, an easy way to understand fluency is by the number of words a person can speak when you assess their spontaneous speech. So the two formal ways of testing it is one is called the category fluency test, where we ask them to name animals, and if they're not familiar with animals, you can ask them to name vegetables or any other categories that they're familiar with. So this is not only a test of language, it is also a front. Also depends on working memory and your memory searching strategies. So you would ask, and it's also a time test. So you ask the person to name as many animals as possible over a period of 1 minute. And a normal person, if they do not have bradykinesia or bradyphrenia, will name about 10 to 12 animals in 1 minute. In the phonemic fluency test, you ask the person to say, in English, you ask them to say FAS, or in the Indian languages, we ask them to say Ka, Pa, Ma, the number of words that they're able to say with this. So this also is a test of fluency. So unless the person is very educated, a lot of our patients find this test a little difficult to do. So if they are literate, you would want to assess their reading. So reading, you would give them, so you want to know whether they're able to read single alphabets, whether they're able to read words, they're able to read out a sentence aloud, and if they're able to read a small story and they're able to tell you the gist, so that is reading to comprehension. So similarly, writing, you want them to write a single alphabet. Are they able to write a word to command? And if they are able to write a spontaneous sentence or writing to command, and they're able to follow such a command. So reading and writing also needs to be assessed. So that's about language. So memory is a function that is tested next, because if you're not able to remember the command, then you can't perform all the other higher cognitions. So memory can be classified as immediate or recent memory and remote memory. Immediate memory is also called as working memory, and that is tested by the digit span. It's also called as attention. So in order to comment on recent memory, your immediate memory has to be good. So recent memory depends on the hippocampal networks for functioning. So there are two components to it. One is the visual memory and the other is the verbal memory. So for visual memory, we give 3 to 5 words and ask them to recall, or you can give a paired set of words and ask them to remember. So if they're not able to remember, you can give one of the words as a cue and see whether they're able to remember. And for visual memory, you can hide 3 or 5 common objects in and around the bedside and see if they're able to recollect. If not, you can show about 3 to 5 pictures and later show them a set of multiple pictures and see whether if they're able to identify what was shown to them. So remote memory, on the other hand, is semantic memory as well as episodic memory. You can ask them historical facts and you can ask them some personal information and see if they remember. So we looked at the 3 main domains. Now we looked at attention, we looked at language and memory. Now we are able to look at other cognitive functions. You want to look at ability depends on normal sensory and motor functions. Also, it means that you should be able to perceive objects that are shown to you, and you should have no motor dysfunction. So only then you can see whether the person has got constructional impairment or not. In that case, you would call it constructional apraxia. So the commonest thing that we do at the bedside is asking them to draw a star, like in hepatic encephalopathy. You can use little more complex pictures depending on underlying diagnosis. And this is a function of the right parietal lobe. The other thing that you would test in the right parietal lobe is ask history of dressing apraxia. So you can also give a person a t-shirt or a kurta and see if they're able to align the long body of the kurta to the long body of the long axis of the person, and see if they're able to wear in the right way. So this is also a right parietal function. So you also can ask them to draw to command. You can ask them to draw a flower pot. You can ask them to draw a house. And clock drawing is a complex function. It's not just restricted to construction. So you need to plan how to draw a clock. You need to draw a circle. Then you may have to draw the numbers. So firstly, you have to be educated. You should have drawn this before. So it's not only a parietal function, but it's also an executive function. So calculations are supposed to be a function of the dominant parietal lobe, which is the left parietal lobe. So you can ask, if they're not well versed with mathematics, you can ask them simple addition. If they're more educated and they're more comfortable with maths, you may be able to give them more written. And this again is a function of whether people are comfortable with numbers and dealing with maths. So if people perform badly on this, doesn't not necessarily mean that they have an underlying cognitive dysfunction. Coming to praxis, praxis is the ability to perform learned motor acts. So in order to assess learned motor acts, you should have no motor weakness, no sensory weakness, no obvious cerebellar signs. You should have reasonably good perceptual ability. So you should know where the object is, and you should know the function of the objects. So when you have normal power, normal sensation, and you should have learned the particular act. Like for example, if I want to brush my teeth, so I should know that I should be able to identify the toothbrush. I should be able to hold on to it. But the way I hold on to it and the way I try to brush will determine whether my praxis networks are functioning or not. So the way we check praxis, which is a left parietal function, is to see whether the person is able to comb their hair. So you can ask them to show action, or if they're able to brush their teeth, comb their hair, or use a scissors. If they're not able to do this, you can give them the real object and see whether they're able to do. So intransitive actions, we use gestures like waving goodbye, saying namaste. So you can use, also you can look at for particular things like blowing out a matchstick, or taking the position of a dancer or a boxer, or kicking a football. So all of these can be used to check transitive and intransitive action that involve the whole body. So this gestural knowledge, like common gestures, is again coded by the left parietal lobe. So you can ask people to imitate gestures. This tells you that the connection between the occipital lobe to the praxis networks in the parietal lobe is intact. So you can give them a verbal command and ask them to follow the gesture, and that will tell you that the connection between the auditory cortex, the language areas to the praxis network is intact. So you can find that sometimes there may be a dissociation between imitation and verbal command, and that is called as a dissociation kind of apraxia. Sequential actions like following a 3-step command used to be called as ideational apraxia. It's actually not a apraxic syndrome, but it's actually more of a frontal lobe dysfunction and an executive dysfunction. So conceptual knowledge and concept of tools is also held in the parietal lobe. So sometimes you may find that if you have a parietal lobe lesion, you will not know the particular function of the tool. So like say, for example, the hammer is for striking a nail, screwdriver is for twisting over a screw. So if this conceptual knowledge is lost, that tells you that the person is likely to have a parietal lobe dysfunction. A person who is not able to perform but who knows the concept tells you that the lesion for the apraxia is outside the parietal lobe. And if they're failing at any of these, you should always try to use a real object. So this is a common picture that we show. So we show them various tools and we ask them what is the function and how they use all of these. It also assesses visual perception. If they're able to identify these objects, especially some overlapping objects like the scissor and the comb. So that tells you the perception is all right. Then we ask them the concept of which one used for. We ask them to show the action which actually tests the praxis. So we also, as a part of the parietal lobe function, we also check right and left orientation. So we ask them to point where is the right side and the left side. If you're still thinking of a parietal lobe dysfunction and the person is normal, then you ask them to show it crossed on the person and sometimes crossed on the examiner, as mentioned in this slide. So there's another syndrome in the dominant parietal lobe called the Gerstmann syndrome, where you have acalculia, agraphia, and finger agnosia. So as part of that, we also try to ask the person to identify the fingers on themselves as well as on the other person. And if you have a problem with that, then the problem is likely to be in the angular gyrus in the dominant hemisphere. So the parietal lobe, so you also check 2-point discrimination, graphesthesia, and stereognosis. This is quite important in syndromes like the corticobasal syndrome, which predominantly involves the sensory cortex. So geographical orientation or topographical disorientation, which is the pathology of that, is basically that you will find that people who get disoriented and lost in space. So this may be like going to a shop and getting lost, or it could be like within the house while going to the bathroom, they think that some other area is a bathroom. So this would mean that you want to find out whether they really have an aim or a destination. So patient may be having a wandering behavior, like people with frontal lobe dysfunction. They may not have any intention, but they just randomly wander around and they're not very distressed by it. And when you find them, they are not very distressed or upset. People with hippocampal dysfunction or medial temporal lobe dysfunction, they want to go home, but they can't find the way. They can't recognize landmarks, so they're distressed. So they have an intention to return, and they're very much, and they have. So that is what we find in temporal lobe dysfunction. Occasionally, you can have epileptic phenomena. You can have epileptic amnesia, where the person temporarily loses awareness, and but they don't know that what has really happened. This can happen both in epileptic amnesia as well as transient global amnesia. So while checking geographical orientation, you can ask the person where they are in the hospital, whether will they be able to find out where the toilet is. They're able to point out in the hospital, and whether they're able to, if you can show them a common map of India or whichever country they're in, and you can actually ask them to show where their city is. A simple way to assess the geographical disorientation is to kind of ask them to draw a small position in their house and point out where they are exactly. Another thing for parietal lobe function is something called as neglect. You will find that patient is not able to pay attention to stimuli on one side of the visual field or all modalities. So easy bedside way is to actually give a line cancellation test where you draw lines on either sides of the field and you ask the person to cross them out. You can also do a line bisection. So you can find that you give a line at least 15 centimeters long and you ask them to bisect it in the middle, and you will find that people with neglect are not able to do this. Coming to visual perception. So to assess visual perception, first we show them simple objects like line objects at home. Once you know that they are able to recognize common objects, that means they do not have a visual agnosia. If you find that the person you show them a picture of an apple or a banana and they are not able to recognize it, but the moment you give it in their hand, they're able to feel it and they're able to recognize it, then you would suspect of visual agnosia. So agnosia is nothing but inability to recognize an object through one modality, but you're able to recognize it through another modality and you're able to name it. So while testing visual perception, first thing you want to rule out is whether they're able to recognize common objects, and if they're not able to recognize, are they able to match? So if they're able to not recognize but they're able to match, then you will think of an associative agnosia. So if they're not able to recognize and they're not able to match, then you will think of an aperceptive kind of agnosia. So once they're able to recognize single objects, you want to know whether they're able to see a complex visual scene, because visual attention is quite complicated. You need to see multiple objects over a short period of time and not overlap one over the other. So the cookie thief picture is one thing that we commonly give. But however, in the Indian context, we find that a lot of our patients actually get quite confused of what's happening. So we have an Indian village scene, which is adapted to the Indian context. So, and the person is asked to describe what they're seeing in this scene. So people who are not entire full picture and able to see only parts of it, it could be that it may be because of neglect, or it could be because of a field defect. And once you rule out these two, then it may be because of something called as simultagnosia, where you're not able to see multiple objects simultaneously. So this is due to dysfunction in the bilateral parieto-occipital junction, which is also called as a balance syndrome. Patients with balance syndrome also have another condition, two other things called as optic ataxia and oculomotor apraxia. So optic ataxia is inability to reach out to an object in space, and oculomotor apraxia is they will not be able to follow voluntary commands to look to one particular side. So going on to visual perception, we also try to ask them to recognize faces. So we ask them to recognize faces from non-face objects. And there's something called as a famous faces test, where this is a culturally modified famous faces test. We show people and ask them if they can recognize all of these personalities. And another aspect of facial perception is, are they able to identify facial emotions? This is also a test of social cognition. Asked to identify whether they're able to recognize the emotions of the people shown here. So coming to higher mental function, which is actually executive function. Executive function is all the cognitive components that constitute goal-directed behavior. So if you take goal-directed behavior, there has to be an intention and a motivation, and you need to have a goal. The goal needs to be broken down into multiple sub-goals, which is called as a set. So you need to start with one set and sequence all of these sets. And as you reach the goal, you need to shift from one set to the other. And to make sure that there is no error in between, you need to monitor these errors. And once it's completed, you need to stop. So that the entire process is called as executive function. This involves both memory, it needs attention, it needs vigilance, and depending on the task, it may need praxis as well. So that is why you do frontal assessments only after all the testing of all the other things. A simple way to do that is to do alternate sequences. So alternate sequences can be a grapheme task where you ask them to draw alternate sequences. So people who have inability to shift from one set to the other will have what is called as perseveration. They'll keep drawing the same pattern again and again, and they will not be able to shift. Similarly, we can ask them to do alternate hand sequences, which is called the palm fist ring test and sequences. So the other thing, important aspect of executive function is the ability to stop when you reach the goal, or when the rule changes, you should be able to stop, especially when the rule consists of complicated sequential tasks. So we do something called as a go, no go task, where there are various ways of doing it. The simplest way is to ask the person to tap on the lap or on the desk. So if you should tell them that if you tap once, the person should tap twice, and if you tap twice, the person should not tap at all. And you will find that patients who have inability to inhibit their responses will continue to tap even when you're telling them the cue is for not to tap. So another important executive function is perceptual component of executive function is the ability to perceive similarities. So similarities and differences are something that can be tested, but you will find that it's easy for patients to say differences, but what we're looking at is actually not differences, but similarities. Similarities is to identify the common group from which these categories are formed. Like say, for example, we show them like a chair and a table. You ask patients, they'll be very happy to tell you the differences between chair and table. But what we want to know is what is a common category from there they're coming from. So, for example, both are furniture. So, answers like both have four legs is not an acceptable answer. So, the ability to form concepts tells you that you're able to see similarities in differing objects, and that is one of the higher cognitive functions. The other thing that we do is judgment, insight, and proverb interpretation. So proverbs are metaphors, and so the answer should not be literally taken. And if they're able to understand the metaphorical meaning of proverbs, that tells you that they have a higher level of understanding, which is also called as metacognition. So judgment is, we give a common example of suppose there's a fire in this place, so what would you do? So if they're able to understand the situation and respond in an appropriate way, then that tells you that their judgment is all right. Insight is the ability to see their current status, both physical as well as cognitive. If they're able to understand that their deficits are there, that tells you that again the cognitive functions are present. So insight may be absent in some people with amnesia, or so it may be absent in certain forms of cortical agnosias and cortical blindness as well. And this may also lead to some issues such as confabulation, where one aspect that we don't commonly test, which is often impaired in social cognition. Two things that we need to know is, one is the most important thing is theory of mind. So theory of mind is to predict what the other person is thinking. So there are some bedside tests for that as well. And the other common thing that can be tested is the mind's eye test, where you show them a picture of a person looking somewhere and then try to infer why they're looking there and what their intentions are. So these are not so commonly used, but it's something that's coming up. Okay, so this is my last slide. So I'm open for some questions if there are any. Thank you.
Has anyone got any questions? Sir, actually in a busy OPD, is there anywhere we can do these tests simplified form?
Yeah, so the most important thing in cognition testing is not any of these testing, but only history. So just simplest thing that you could do is just listen to the patient's history, and arousal and awareness is something that's very easy to test. If the patient is sitting there and talking to you, then you know that they don't really have any state function dysfunction, and the rest of channel function is just the history that the patient is telling you. So these are things that you don't really need to do in the OPD. It's something that's so just the history would suffice from the OPD point of view.
So are there any lobe function tests like that?
Yeah.
Overall, this is overall, but
yeah. So these are whatever we discussed. The lobe function is a very old concept. So the current concept is that a lot of brain functions are interdependent on each other. So there's nothing that is a completely separate lobe function. But of course, there are some localizing values. Like say, for example, episodic memory is a temporal lobe function. Like language is a lateral temporal lobe function, and praxis is a dominant parietal lobe function. And frontal executive function is both prefrontal and a parietal lobe function. So,
If there are any questions, please share in the chat box.
Any questions?
If there are no questions, we'll wind up for today. Thank you, everybody, for listening patiently. And thank you very much, sir, for coming and doing this lecture. Thank you, everybody.
Yeah. Thank you all for joining.